Ma'am, we are live on YouTube. Go ahead. Please start. So, good evening, respected faculty members, and to all the participants joining us this evening through our YouTube channel. A very warm welcome to you all to our 11th webinar series from Team Nephrocon. Your active participation and engagements have contributed to the success of our previous webinars, and we are eager and excited to continue this journey of knowledge sharing and collaboration. The theme for today's webinar is Conquering Lupus Nephritis, and we thank our distinguished speaker and esteemed panelists who have generously shared their time and knowledge in making this event possible. We are live through our YouTube channel, and you all are encouraged to actively participate in the discussions and share your thoughts in the YouTube chat box. So without any further delay, let's get started. So we would be having the talk first, followed by the panel discussion. And I feel honored enough to welcome our speaker for today's session, Dr. Pooja Maheshwari, ma'am. She is a lab director and chief renal pathologist at Renal Path Labs, Gurgaon. Ma'am brings with her a vast experience of more than 15 years in the field of renal pathology. She has done her MD pathology from BG Medical College, Ahmedabad, and PDCC renal pathology from SGPGI, Lucknow. She has numerous papers to her name, and her key interest is in renal pathology, immunofluorescence, and electron microscopy. So I would invite ma'am to kindly initiate her talk now.
Thank you, Seema. Thank you, Nephrocon, and thank you, Dr. Purva, for inviting me and choosing this topic. So I'll just share my screen. I hope my screen is visible. Okay. So topic is lupus nephritis, and the dilemma never ends. For a new pathologist, this may be a nightmare when a biopsy of lupus nephritis comes and there are 2 or 3 cores, and then you have to count all the cores. Sometimes there is a lot of confusion if the concepts are not clear. So whether it is a crescent or not, which crescent it is, whether it is class 4, whether it will go into class 4+5, whether there are wire loops or not. So I will just try to relieve some of the tension to report lupus nephritis cases, and my main focus will be on histopathology and including light microscopy and DIF. So we will discuss introduction, classification schemas, terminologies used, activity and chronicity indices, vascular lesions in lupus, briefly about lupus photocytopathy, and some case discussion. So lupus nephritis, as you all know, that is an immune complex mediated renal injury encountered in SLE, and it is associated with activation of classical complement pathway and presents as glomerular, tubulointerstitial, and vascular disease. And it significantly increased the risk of ESRD or death in SLE. So what are the key characteristics? First, we should have clinical diagnosis of SLE to call it as lupus nephritis. Then light microscopy and DIF are essential for correct classification of lupus nephritis. And then the class is determined by histological type of glomerular changes that include mesangial, endocapillary, membranous, or sclerosing pattern, and the localization and abundance of immune complexes. Now, most important thing is full house immunofluorescence staining, and in that, significant C1q positivity is the key feature along with IgG deposits. And one most important thing is extraglomerular immunostaining. So briefly, I will refer to it, EG. And then the finding of TRIs by electron microscopy is just a help in establishing the lupus etiology of nephritis. It's not essential. So the most important thing is DIF. What is full house DIF? The constant feature in all the classes of lupus nephritis is full house pattern in IF examination, and it's not an absolute criteria. So what is full house? Expression of all immunoglobulins, IgG, A and M, and complement components C3 and C1q, as well as kappa and lambda light chain in the glomerular compartment. That is, you can see a glom here, and there's a lot of extraglomerular deposits. So IgG, A and M all can be positive along with C3 and C1q. For the diagnosis of LN, dominant IgG and C1q deposits are absolutely required, and there can be variable co-deposit of IgA and M. But it is not necessary that we will find A and M in all the cases. The most important, or I can say most specific finding for the lupus nephritis is extraglomerular staining, that is EG for immunoglobulins and C3 and C1q. So what happens if we have, we have only medulla, but there is immunostaining for IgG or complement along the tubules or along the PTCs or along the vessels also. If we don't have any glom, but we can find the EG, extraglomerular deposit. So that is specific for SLE in all the cases. So this is a picture showing like these are all glom, brightly staining with the IgG. And you can see that there is a lot of extraglomerular stain. So this is capillary wall positivity also, and in between also. So depending upon the classes, there may be different staining, the different staining patterns. And one other thing is tissue ANA phenomenon, because ANA is positive in most of the lupus cases. So this picture is showing bright staining in the glomeruli, as well as you can see that these positivity is in nucleus. So these are tubular nuclei because ANA is positive. So not in all cases, but in many cases, we can find tissue ANA phenomenon. This is another example in which there is no glom in this case, but if we find some like tubules are there, and here also some tubules are there. So if we find bright staining for IgG or any other light chain or complement component, so that is enough to diagnose or to call it as SLE if like clinical suspicion is there. So classification schemas. So firstly, WHO classification 1974, basically there are 5 or 6 classes in every classification. And I will just focus on ISN RPS classification 2003 and then the update. So class 1 was minimal mesangial lupus nephritis, 2 was mesangial proliferative, 3 was focal lupus nephritis. And before the recent updates, it was divided into third active A by C or chronic lesions. So now they are obsolete terms, but if the biopsy, if you can see them in, if the patient is old and you are looking at the old biopsy report, then you can find them. Then the fourth is diffuse lupus nephritis. And that was also divided into A by C and C. Fifth was membranous lupus nephritis. And sixth was advanced sclerosing lupus nephritis, when more than 90% glomeruli are sclerosed. So what we follow now, that is the recent classification, ISN RPS 2018 updates. So class 1 is minimal mesangial lupus nephritis. 2 is mesangial proliferative lupus nephritis. Third is focal. Fourth is diffuse. Fifth is membranous nephropathy or MLN. And sixth is advanced sclerosing. In like my practice or in a renal pathology practice, 6 rarely comes and 1 also rarely comes. So the most common is 4 and 4 plus 5 and then 3 and then second. We rarely find class 1 or class 6. Briefly about terminologies. Focal is lesion involving less than 50% of glomeruli. Diffuse is lesion involving more than 50% of glomeruli. Segmental is lesion involving less than half of the tub. Global is lesion involving more than half of the tub. These terminologies will be like important when you see a renal biopsies. What is mesangial hypercellularity? So previously it was like 3 nuclei in mesangial region. Now the criteria is there should be more than 3 nuclei fully surrounded by matrix in more than 1 mesangial area or even in 1 mesangial area. That should not include perihilar region on a 3 micron section. So you can see here, this is a hilar area. This is a mesangial region. There are a lot of more than almost 7 to 8 nuclei are here. And even if like in one mesangial area, you will find this, you can call it mesangial hypercellularity. What is a crescent? Crescent is a lesion consisting of extracapillary hypercellularity forming more than 2 cell layer. And it can be composed of variable mixture of cells. So fibrin and fibrous matrix may be present, and the current threshold is 10% or more of the Bowman's capsule should be involved. What is cellular, fibrous, and fibrocellular crescent? Cellular is when more than 75% cells are there and fibrin, and less than 25% fibrous matrix. Fibrous is when there is more than 75% fibrous matrix and less than 25% cells and fibrin. And fibrocellular when there is 25 to 75% cells and rest is the matrix. So you can see that here, like almost many cellular, this is a cellular crescent, only this may include parietal epithelial cell, visceral epithelial cells, and inflammatory cells, and a lot of macrophages and inflammatory cells also. And this you can see, this is a matrix, this is a healed crescent or fibrous crescent, and this is a mixture of matrix and cells. So this is a fibrocellular crescent. This is important because like then it will make it will be involved in activity indices and chronicity indices. Am I going too fast? Okay, so fibrinoid necrosis, that is fibrin associated with glomerular basement membrane disruption or lysis of mesangial matrix. What is karyorrhexis? In this picture, you can see presence of apoptotic, pycnotic, and fragmented nuclei. Here you can see that dark blue color nuclei. This all is karyorrhexis, and the reddish part is necrosis. My slides are visible, I think.
Yes, ma'am. If they're visible.
Okay.
Yeah.
So this is a cellular crescent. This is a tuft, and the capillary walls are thickened over here. And this dark blue material is karyorrhectic debris. The reddish part in between is the fibrinoid necrosis. We will see more pictures. And adhesion was also defined recently that it is an area of isolated continuity of extracellular matrix material between the tuft and capsule, even when the underlying segment does not have overt sclerosis. Sometimes there is confusion between that this is a partial crescent or sclerosis or adhesion. So now this is defined. So what changes were made? Changes made in 2018, basically class 2, as I told you, that the definition for mesangial hypercellularity was adjusted. 4 or more nuclei should be there to call it as mesangial hypercellularity. Class 3 and 4, just a second. Dr. Purva, my PPT is visible now? My
Yes.
PPT or slides?
Yes.
Okay. What's going on here? Okay. So class 3 and 4, the term endocapillary proliferation was replaced by endocapillary hypercellularity. Previously, the term was endocapillary proliferation. Now we call it as endocapillary hypercellularity. The crescent were defined, the criteria or threshold to call it cellular, fibrous, fibrocellular were defined, adhesion was defined, and there was elimination of segmental and global subdivision of class 4. So previously this was like class 4 S or G for segmental and global. Now there is no such subdivision, and then there is we have designated activity and chronicity indexes, and we have removed A active, C, and A by C. And for tubulointerstitial lesions also, this is recommended that we should mention that whether the interstitial inflammation occurs in presence or absence of interstitial fibrosis for obvious reasons. Previously, there was a lack of some cutoff values. So you can see here that this is a endocapillary cellularity, this is a crescent, and this is silver stain, this is necrosis here, and these are wire loop lesions. They are bright, like eosinophilic capillary wall thickenings. So what are adequacy or prerequisites to for a renal biopsy? The renal biopsy should include minimum 10 glomeruli to exclude the existence of focal lesions. The renal biopsy should be studied by IF, including G, AM, kappa, lambda, light chains, and C3, C1q complement components. All should be done. And EM is like optional. It's not essential. Coming to activity indices and chronicity indices. So these 6: endocapillary hypercellularity, neutrophils or karyorrhexis, fibrinoid necrosis, hyaline deposits that are wire loop lesions, cellular or fibrocellular means active crescent, and interstitial inflammation. So we see these these parameters in a particular kidney biopsy. Then we count all the glomeruli. Then we see that endocapillary hypercellularity is present in the range is like 25%, 25 to 50, or more than 50%. So say in a particular biopsy, if they are more than 50%, then it will be scored as 0 to 3. And scores for all the parameters are 0 to 3, except fibrinoid necrosis and crescents, because they are more like related to the prognostic. There are more important prognostic factors. So all the parameters, endocapillary hypercellularity, neutrophil karyorrhexis, they are scored as 0 to 3. Then fibrinoid necrosis, 0 to 3, then it is multiplied by 2. Then wire loop lesions, 0 to 3, again, that if they are present in more than 50%, it will be scored as 3. Crescents, again, multiplied by 2, and interstitial inflammation. That may include like neutrophil monocyte. You have to mention that whether like what is predominant plasma cells are there, or neutrophil or lymphocytes. So it is again scored as 0 to 3. So total score is 0 to 24. Coming to chronicity indices, that is total glomerulosclerosis score. There are 4 parameters: sclerosis, fibrous crescent, tubular atrophy, and interstitial fibrosis. So again, 0 to 3 scoring is done, and in that there is no multiplication by 2. So the total scores come as 12. So there should be an idea of these all parameters, and whenever we see a biopsy, like you can mention each, you have to count all the glomeruli, you have to see all the parameters. So that way it becomes difficult. But once you remember, like I'll tell you that if any particular proliferative lesion, so say endocapillary hypercellularity, is present in more than 50%, so automatically it becomes class 4. So even if like the top above like 5 criteria, if they are present in more than 50% glomeruli, any one of them, so the case automatically become class 4 lupus nephritis. And if any one of the criteria, like all the criteria, any of the criteria is in less than 50%, this becomes class 3. So minimal mesangial lupus nephritis, it is like minimal mesangial lupus nephritis with mesangial accumulation of immune complexes that can be identified by either DIF or by DIF and EM without any light microscopic alteration. So there is no normal looking glomeruli on light microscopy, and there is presence of immune deposits on DIF or EM. Now, this represents earliest and mildest form of glomerular involvement. Normal urinalysis is there, no or minimal proteinuria, normal serum creatinine, so it is rarely biopsy. Class 2, any degree of mesangial hypercellularity, as I told you, that it is defined as 4 or more mesangial cells per mesangial area in a 3 micron thick sections in association with mesangial immune deposits. So on DIF, you will see like mesangial immunostaining for particularly IgG and C1q light chains should be there. And by GIF or electron microscopy, there may be rare, isolated, small immune deposit involving peripheral capillary wall in some examples. So I'll just show you a picture of EM. You can see that this is a capillary wall. This is mesangial regions. The dark staining, these are all electron dense deposits. So this is mesangial area, and you can find many mesangial deposit, mesangial electron dense deposit in the mesangial area, but definitely there should not be any endocapillary cellularity. Even if in like one glom, you are sure that this is endocapillary cellularity or necrosis or crescent, this will become class 3. So you should be very careful to like call it as mesangial lupus nephritis. You have to see all the sections and all the glomeruli. Class 3 focal lupus nephritis, it is defined as when proliferative activities involving less than 50% of all the glomeruli. DIF may show full house or IgG dominant or C1q positivity. And on DIF, like mesangial or mesangial plus capillary wall deposits can be there in focal lupus nephritis. So you can see that like in these glomeruli, there is this one is a crescent, but largely there is no like this is segmental endocapillary cellularity over here, and this is a small crescent with endocapillary cellularity here. But all like the remaining part of the tuft is almost normal. So if endocap is in less than 50% glomeruli, endocap, necrosis, wire loop, or crescent, if any of them like in less than 50% glomeruli, it is focal lupus nephritis. And as I said, if any one of them is in more than 50%, it will become class 4 lupus nephritis. So in class 4 and 3, only difference is the number of glomerular involvement, less than 50 and more than 50. This is a picture showing like this is diffusely proliferative glomerulus. Lot of endocapillary cellularity here. This is a segment showing endocapillary cellularity. These are like thickened capillaries here with wire loop lesions. And on IF, you can find capillary wall deposits as well as mesangial deposits. On EM, in particularly, there is more, the extent of the electron dense deposits is more in class 4. So these large, chunky subendothelial deposits are there. These are all subendothelial deposits. And you can rarely see any deposits, any immunostaining here. So these are mesangial deposits. Class 5 membranous lupus nephritis, it's diffuse capillary wall deposits along the glomeruli, along the capillary wall, and only capillary wall thickening. No endocap should be there. So there is continuous granular subepithelial immune deposits, and it can have some mesangial immune deposits, and any degree of mesangial hypercellularity may can also occur. So this is a silver stain. You can see that this is a mottling here, and this is empty stain. So these are like reddish subepithelial deposits. Also, you can identify here. This is DIF. This is again a silver stain showing beautiful mottling, and this is EM finding. So in membranous, there are a lot of subepithelial deposits in the capillary wall. So the criteria is more than 50% capillaries should have subepithelial deposits. Class 6, that is advanced stage lupus nephritis, it designates those biopsies with more than 90% global glomerulosclerosis, and in which there is clinical or pathological evidence that the sclerosis is attributable to lupus nephritis. That is important. And it is also rarely seen in clinical practice. So this is a beautiful diagram. You can see that the reddish red cell is mesangial. Okay, so this is class 1. In class 1, there is the blackish part is immune deposits. So in class 1, there are mesangial immune deposits, but no mesangial cell hypocellularity. So these red are mesangial cell. In class 2, the number of mesangial cells increases and there is more deposits here. So this is class 2. In class 3, what happens that there is endocapillary influx of leukocyte, along with that mesangial hypercellularity and lot of deposits here. So these are subendothelial deposits and these are mesangial deposits. And in class if the 3 or 4 are combined with 5th class, then these deposits, like just below the podocytes, are subepithelial. So if it is combined with class 5, there are a lot of subepithelial deposits. And in only class 5, you will not find, or you will find very rare subendothelial deposits. There will be predominance of subepithelial deposits. So coming to vascular lesions, they can be like classified as vasculitis with inflammatory infiltrate. It's a well-described lesion, and it is combined with necrosis and adjoining high inflammatory activities. What is lupus vasculopathy? This is non-inflammatory. There should not be many lymphocytes or inflammatory cells, and it is defined as luminal narrowing of arterioles or terminal arteries by intramural immune deposits that is typically admixed with fibrinoid changes. What is isolated immune deposit? It is like only, there is no apparent prognostic implications, only detected by IF. What is TMA? When there is no immune deposits by DIF, but there is like necrosis or RBC fragmentation or thrombotic occlusion, and then arteriosclerosis. So I'll just show you pictures. And then this is a lupus vasculitis case. You can see that the reddish part is necrosis, and all these are inflammatory cells. So when the necrosis is mixed with a lot of inflammation in the vessel wall, this is called lupus vasculitis. And you can see here that there is no inflammatory cell here. So if the DIF will be, in DIF there is vascular deposit, so this will be lupus vasculopathy. This is TMA. You can see here that beautiful RBC fragmentation all over the wall. This is necrosis. And in hilar arteriole also, so you can see thrombotic occlusion. So what are current suggestions for lupus nephritis classification and reporting? We should first classify according to class 1 to 6. Then we should give activity and chronicity scoring system, modified NIH activity index 0 to 24 or 0 to 12. Then we should include additional feature, whether there is atypical morphological pattern, whether there is collapsing, any glomerulus showing collapsing FSGS or tubulointerstitial lesions. We should describe lesions different than those specified in the scoring system. Then we should specify vascular lesion. And then if EM is done, we should include electron microscopy findings and previously used features with questionable usefulness. So this we don't use nowadays. At A by C, or S or G. Briefly about TRI, tubuloreticular inclusion are distinctive cytoplasmic structure of unknown origin that typically associated with autoimmune and viral diseases, can be seen with alpha interferon therapy, HIV, and few other incidents. So this you can see, they are mostly seen in endothelial cells. They can be seen in either peritubular capillary cells or these endothelial cells. So this is beautiful tubuloreticular inclusion over here. This is not specific for SLE. This can be seen in other diseases. And sometimes we can see fingerprint structures. They are organized mesangial deposit with tubulofibrillar substructure. I'll just show you the picture. And EG. So sometimes on EM, you can see the extraglomerular deposits in the form of electron dense deposit. This is a PTC and this immune deposits. So I think I have time to discuss 3 or 4 cases.
Ma'am, we'll have to have a panel discussion now.
Okay. Thank you.
I'll just request Seema to share her slides and then we can move on. Thank you, ma'am. It has been a wonderful presentation. Actually, we used to, like when I was training that time, we used to have that AC classification that was being used. Now it has, of course, simplified a lot, but then if class 3 and class 4 is the tricky diagnosis which we depend on, and probably most of the cases, if they are undergoing rebiopsies also, is to see whether, class 3, class 4 lupus is present or not. So thank you for a wonderful presentation. We'll just move on to the next panel discussion. But before the panel discussion, I have one question for you. And that is, the histopathological classification focuses a lot on the glomerular and vascular lesions. And in a proven case of SLE with biopsy-proven tubulointerstitial injury, Is there any place for these cases in the classification? Because we don't, like, there have been cases where SLE, ANA is positive, DSDNA is positive, but no glomerular lesion, just some tubulointerstitial injury reported on biopsy.
Yeah. So in my practice, like the biopsies showing only tubulointerstitial lesions are really rare. You can say that between 2 to 5% of all SLE cases. But definitely we should mention them, and this is more common in other autoimmune disease. Like they are more common in Sjogren's disease, they are more common in scleroderma also. So we should include that, but I also like suggest that the vascular lesions should be also included in the activity scores. Here, like there is, it's not involved, it's not included in activity score or chronicity score. So along with the vascular lesions, like we may specify that only tubulointerstitial compartment is involved, but definitely in my practice, the cases are rare.
Okay, thank you, ma'am. We'll go on to the next slide. So when a nephrologist suspects lupus, we're basically wanting to either achieve remission, prevent relapses, or slow the progression of lupus nephritis. Screening for lupus nephritis is more or less done by the physician or a rheumat. It becomes a lot easier to diagnose lupus in a proven case of SLE, lupus nephritis. So it nonetheless, a positive ANA, dsDNA, low complement levels make our job easier in the background of sole lupus to be diagnosed if an SLE case is not diagnosed. And then we move on to immunosuppression therapy. So this is a small, this is a short slide having everything what we do as a nephrologist to treat lupus nephritis. Next slide, please. So, as everyone must be aware, KDIGO has released lupus nephritis specific guidelines this year with a lot of emphasis on treating each class more, class 3 and class 4, and also treating lupus with thrombotic complications, pregnancy. These also have been given special consideration. The FDA has approved 2 drugs, that is voclosporin and belimumab. However, they are not available in India. There are a lot of drugs in the pipeline, one of them being obinutuzumab, showing promising results. So next slide, please. These are the various trials one should go through. The landmark trials are Eurolupus and the NIH regimen have paved way, and clinical practice revolves more or less around these regimens. So of course, with new data coming in, next slide. We have these drugs in pipeline, and there have been 2 trials that have been recently completed in the month of September called the Regency trial and the Phoenix trial, and of which this drug obinutuzumab is having promising outcomes, especially in cases of lupus nephritis. The ones which you can see in orange here are phase 3 trials, and the gray ones are phase 2 trials. Next slide. So with that background, we'll now move on to our panel discussion, for which we have 2 esteemed nephrologists, Dr. Rishi Deshpande, sir, from Mumbai. Welcome, sir. Rishi, sir, are you there?
Yes, hi. Good
Good
evening.
evening, sir. And we have Dr. Santosh Hedau, sir, from Hyderabad. So you're most welcome, sir, both of you.
Thank you.
Yeah. So we'll begin the panel discussion with Santosh, sir. Next slide, please. So, sir, I'll go ahead with the first question. SLE patients may be receiving methotrexate, NSAIDs, leading to kidney injury. So in this case, how do we differentiate from lupus nephritis, and should kidney biopsy be done in all?
Yeah, that's a good question. So basically, anybody who has a glomerular disease, and if we are suspecting any other disease on the top of that, we should have some background. So methotrexate usually, if we come to methotrexate specifically, we see nephrotoxicity in high dose methotrexate exposure, which is common more in malignancy cases. So right now I am in a setup where I see a lot of cancer patients. In them also with high dose methotrexate, toxicity is not much, but there will be more tubulotoxicity. And we come to NSAIDs, which our lupus patients will use more frequently because of joint pain and all. So, see, we have to rule out all possible common causes, and then there will be a history of taking NSAID that we have to take not with one or two tablets. There will be a recurrent history of taking NSAID and more of a interstitial presentation. Whereas our patients for nephritis presents with more of a glomerular presentation. So they will have more of proteinuria, edema, and all. At the same time, if there is a doubt, we can always do complement levels, which will help us to understand if they are going down in a otherwise well-controlled lupus nephritis patient. We may understand that probably it is related to lupus rather than NSAID, but very difficult sometimes. So, if we have stopped the offending drug, we are not seeing any recovery in kidney functions, and the non-invasive tests in the form of complements are not helping us. Probably biopsy should be done, but definitely not in all cases. We can always go for the conservative treatment, like stopping the offending drug, and then wait for some more time, do non-invasive test, and then see. That's what
Right.
I think is the proper way.
Right. So, sir, despite of a well-controlled lupus, can lupus nephritis SLE, despite of well-controlled SLE, can lupus nephritis still develop? And how would you monitor SLE patients for detecting early detection of lupus nephritis?
Yeah. So, see, in a well-controlled SLE, lupus nephritis, although rare, but it can happen. There are few cases which I remember were diagnosed only on the basis of renal biopsy. Actually, they didn't have much of extra renal features. And many a times we see the different system involvement may not be present altogether in the same patients. Some patients may have more of skin, some may have more of hematological, and some may not have renal at all. So they may present separately or in combination. Isolated lupus nephritis, although rare, but can be present. And even in a well-controlled SLE, lupus nephritis can develop. So, but although it is rare, how to monitor SLE patients for early detection of lupus nephritis. So again, clinically only we have to go. So if they are developing pedal edema and all, or if they are developing hematuria, although gross is not very common, but we have to do their urine routine and urine protein regularly, because that is the place where we'll pick up the early involvement, and we can pick up the disease early and treat effectively. Uh, I think that's the thing for early detection. We have to detect regularly, do regularly urine routine and urine spot protein. That will help us. Usually, people say the complement levels and dsDNA are also a strong predictor of development of lupus nephritis, but we can't do them regularly. Whenever we suspect, we can do that to just support our diagnosis.
So, do you monitor dsDNA titers for patients on immunosuppression to monitor lupus activity?
No, usually once they are an immunosuppression and they are well diagnosed case, I usually do not monitor. But when I am going to wean or stop the therapy, then before doing that, before weaning immunosuppression, I do check dsDNA levels and complement and see if they are okay. Then I start weaning.
Okay.
Or if there is any change in proteinuria and creatinine in otherwise stable patient who was on regular immunosuppression, then I do check these levels, not regularly.
Mhm. So, sir, how often have you used plasma exchange in lupus nephritis?
Frankly speaking, very rare. I remember only one case of diffuse alveolar hemorrhage. There were few cases where we thought we can use that. One was neuropsychiatric lupus, and second was catastrophic APLA. But in those two patients, we did not use. Only one in diffuse alveolar hemorrhage we had used plasmapheresis.
Right. even the KDIGO guidelines suggest to use the plasmic score, and if there is a concomitant TMA with
Hmm.
lupus.
Yeah, TMA definitely, even the survival benefit is there, and there it is more useful.
Right. So last question, what is the role of SGLT2? Because this is the most
Yeah.
upcoming.
So now SGLT2 inhibitor is finding its place everywhere in nephrology. But as far as lupus is concerned, when I went through the data, what I saw is patients who have diabetes and lupus, there is definitely a survival benefit, and renal outcomes and cardiac outcomes are much better. But I could not see any specific trial which was very sure about SGLT to use in isolated lupus nephritis patients and outcome. Probably in future we might get some useful data on this.
Okay. Okay. Thank you, sir. I have more questions for you, but before that, we'll go ahead with Rishi, sir.
Yes. Thank you.
Good evening, Rishi, sir.
Yeah, hi Purva.
Sir, should I directly dive in to the first question? Sir,
Yeah.
would you bother correlating every ANA done by immunofluorescence with a 1:200 or 1:320 in a new case with proteinuria as a case of lupus?
So, I mean, theoretically, what is the level of ANA at which we should get worried was always a question. That being said, now with the KDIGO guidelines saying even 1 in 80 is significant with IF, I suppose, we'll have to give the benefit of doubt to the patient that the ANA may correlate in a pathological way with the proteinuria that the patient is having.
Okay.
Am I
So,
audible, Purva?
yes, sir. Yes, sir, you're audible. So, theoretically, sir, this is possible. Clinically, would you like filter these patients out? But because sometimes we're seeing men also having a frequent ANA positive, like 1:200, and but then we just don't.
So, more often than not, an ANA less than 1 in 320 will be unlikely to correlate with the proteinuria in a causative way.
Right.
In clinical practice, that's what we observe.
Yeah.
Right.
Right.
If it was not, however, when you look at the newer guidelines coming out, they seem to be lowering the target of ANA at which we should be concerned. So that's
And
why.
so go ahead. You're muted, sir.
Yeah. Sorry. So at these levels, we should be careful of not. See, basically, with lupus, one thing we have all seen and learned is that lupus is a disease in evolution. So, at all different times, different things become more relevant in a patient. That is, they might not present with everything at the same time.
Right.
Before just writing off an ANA as a false positive or anything like that, it is important to keep that in mind also. And that is one of the reasons why this ANA titer has been brought down in the newer guidelines.
Right.
Because what people have observed is when you write off, suppose an ANA of say 1 in 100 or 1 in 160 as not significant, and later you have to, you will be caught on the wrong foot when after 6 months, 1 year, these patients come with a proper full-blown lupus, satisfying all your criteria.
Right. And then I think we can use ANA, dsDNA, maybe anti-Smith and C3, C4 levels, a combination of all of them, and then probably have a better
Like I
diagnosis.
said, in clinical practice, what we all see is that it's very easy when they are satisfying all the criteria that we are looking for.
Yes.
The question is when they are not satisfying all the criteria,
Right.
will they still evolve into a lupus in the future?
Yeah.
Or in the near future, rather, in most patients.
Yes. So the next question is, what regimen has worked best for treating vulnerable lupus nephritis, especially the class 3, class 4, and cases having high probability of progressing to end-stage renal disease?
Yeah. So, in addition to steroids, that's how we always go. We have 3 choices, right? We have MMF, we have cyclophosphamide, and rituximab. So choose your whichever one you are going to go with.
Mhm.
MMF, in personal use, I have used more of MMF than the other two in patients with class 3, class 4 lupus, because A, it is good for both maintenance and induction, equipotent. So it's easy to start the patient on the same drug and carry through with it. When you use cyclophosphamide, you are always worried about the side effects. Even though it is a very, very good drug in clinical practice, side effects do bother us. Rituximab, personally, I had decent experience with rituximab, and I kind of was surprised to see that the newer trials show that rituximab is not reaching the primary endpoints and is falling out of favor from the KDIGO guidelines. So that actually came as a surprise. So I was discussing with rheumatology colleagues. So there was a rheumatology symposium in Mumbai recently, and I asked them that the newer KDIGO guidelines are basically rituximab is getting billed in most indications for lupus nephritis, and but their experience is very contrary. From the rheumatology point of view, rituximab still remains the drug of choice for lupus. So they are actually very surprised why is KDIGO not saying that rituximab is kind of, but then I went back and looked at the data that KDIGO used before saying that rituximab is not so great. And when you look at the studies, they are well done studies. So there's no reason to say that in my experience things are different. So I suppose we'll have to believe that rituximab may not be a great drug of choice when it comes, and we might be left with more of MMF and cyclophosphamide for class 3, class 4 at the minute, till we get our hands on voclosporin and belimumab. Still, belimumab, I think only 3 or 4 of my patients have used so far. They have managed to get it from outside and use it. Voclosporin, 2 patients are on currently. Personally, belimumab I have not had a great experience with. These 4 patients who took belimumab, I don't think they did very well. So I don't know what it was. It was class 4 where belimumab was used. So one of them was from UK, and he was started there, and we continued with belimumab here. But personally, whatever 3-4 patients I have seen on belimumab, no great experience, no great results.
Okay.
So to cut the long story short, steroids plus MMF as primary, and cyclophosphamide or rituximab as the second drug.
Right, right. That answers my next question already, so I'll just skip that. How do you manage coexisting APLA syndrome with biopsy-proven lupus nephritis?
I suppose treat it like a class 3, class 4, and just add a anticoagulant.
Yeah. Okay. Okay. Yeah. Fair enough. So, what is your take on pregnancy after sustained remission of lupus nephritis?
That's a tough one. So 6 months of immunosuppressive drugs or on stable low-dose steroids without any clinical flares, if somebody wishes to get pregnant. However, we need to counsel them really well for everything, maternal and fetal problems that may develop. Maternal particularly because the incidence of hypertension is definitely higher, so is the incidence of renal dysfunction, and peripartum is the most difficult time when we see a lot of lupus flares.
Yes.
And they even though they want to dive into it, a lot of them have problems with the fetal growth. IUGR is not infrequent. Placental insufficiency is not infrequent in this group of patients. So, uh, even though we have had patients who with lupus in remission who have had a successful outcome with the pregnancies, not something that I recommend to people unless they are the ones who are kind of desperate wanting it.
Right.
Particular problem comes in patients with lupus post-transplant, but that is even more difficult.
Yeah. We'll discuss that in a bit, sir. So KDIGO is advising taking HCQS and aspirin in
Yeah.
all patients who are
Totally.
wanting to get pregnant despite of
Totally.
having. So we come next slide, please. So we'll now discuss lupus nephritis and kidney transplantation. And again, I'll now ask Rishi sir only as my first question. Rishi sir.
We'll go to Santosh first. I don't mind.
Okay, all right. So, sir, what strategies do you adopt pre-transplantation in a patient with end-stage renal disease due to lupus nephritis and APLA syndrome?
Okay. So see, usually in autoimmune diseases, there is always a discussion about whether we should wait for disease to become quiet or burn out and then go for transplant. But again, this is very controversial. Waiting in lupus is controversial. Like for anti-GBM and all, we wait for 6 months and all till the antibody becomes negative. But here, most of the people now do not recommend to wait for transplant if there is no extrarenal active disease. Say renal is already burnt out, but if there is no extrarenal disease which is active, we can go ahead with the transplant. The serological activity usually does not correlate with the recurrence in the graft. So people have seen that. So that's why it is not recommended to wait till all the antibodies become negative, all complements become normal. They mainly look at now extrarenal symptoms and extrarenal organ involvement. If that is quiet, we can go ahead. Then regarding APLA syndrome, see, they will be on anticoagulation. So echo has to be there definitely. And if there was a thrombotic event earlier, we have to put them on anticoagulation also, along with echo.
Sir,
When would you? Yeah.
do you do you pre-transplant, do you do C3, C4 levels or the just to say if the disease is burnt out or not?
No,
Because
that's what I'm trying to tell. So serological activity does not correlate with the recurrence. So there is no point in doing that. Better to look at extrarenal disease if it is active
okay.
and
So
if that can interfere with your transplant. So if
okay.
that is not there, we can go ahead. See, I said it is controversial, but the present understanding is that not to wait.
Yeah.
So, yeah, if you wait and wait for the disease to become quiet, disease means serologically, then actually you're wasting time, and this patient will have more and more time getting exposed to dialysis. Even people
Right.
have recommended now preemptive transplant for these people can be attempted,
So there's no way.
irrespective of their, yeah, irrespective of serological status.
Okay. And
So,
sir,
APLA, yeah,
yeah,
sorry.
please go ahead. Please go ahead, sir.
For APLA, same thing, echo screen. And if there was a thrombotic event earlier, then we can go for anticoagulation along with echo screen.
Right.
And when would you suspect recurrence of lupus nephritis after transplant? So see, usually recurrence is less as lupus nephritis is a very good disease to manage on transplant. I mean, lupus nephritis patient, usually 2 to 10% only, if I remember. And because obviously the treatment of lupus is what we are giving the patient in the form of transplant medicines. But still, if there is a creatinine rise, if there is proteinuria, again recurring hematuria, we have to suspect the recurrence of the disease. And in these cases, biopsy only will answer. So, because it's very difficult to differentiate clinically, rejection can also present in the similar way. And if we just assume it is probably lupus based on serology and other things, we are going to miss rejection, and that will be more probably risky thing to handle. So, in such cases, biopsy is the better answer. And the recurrence can happen as early as first week, and up to 15 years, 16 years later, also the disease can recur. So we have to biopsy and find out in such cases.
Right. Actually, KDIGO has not many things specific about post-transplant lupus, nephritis or whatever. But then I think immunosuppression should take care of prevention of
Correct.
recurrence. And
Correct.
maybe we can continue HCQS
Yes.
transplant.
No, but
Prevent.
suppose you have a recurrence, Purva, how would you treat it any differently than what you are on post transplant? What would
Right.
you do?
So now,
So, yeah.
yeah, please go ahead, sir.
Yeah. So no, usually it's always switch over to if see they are on MMF already. So if on MMF they have got recurrence. So for any relapse or any flare, obviously steroid pulse, and then slowly you can wean the steroid. And in place of MMF for 6 months, you can put on cyclophosphamide, and then slowly switch over to MMF again after 6 months. That's what is probably done.
Okay. I have no experience about this, sir, so I'm
I
not.
have not seen any recurrence of SLE post-transplant, to be very frank. But that's what I came to know when I went through the literature. So this is what is being recommended because they are
So,
already on mycophenolate. So we have to switch over to endoxan that will give a better control of disease probably.
so I just had one patient in this all time when I had a recurrence of lupus post-transplant around two and a
Mhm.
half, 3 years post on 1.5 grams of MMF and tacrolimus patient was on. And the rheumatology colleague whom I had involved insisted that we use rituximab.
Hmm.
And actually the patient had a very good result.
Okay.
So that's why I brought that up, that maybe rituximab is one another thing that should be considered if you do have a recurrence post-transplant.
Right. So most of these
Yeah.
guidelines are already in the American this thing, so we might have to have our own data now to
Yeah.
rituximab being useful in lupus. Any comments about anything else, sir, you want to add about suspecting recurrence of lupus after transplant? Rishi, sir? Okay. So we'll go to the next question to Rishi, sir. Rishi, sir, are you there?
Yeah, very much.
So, do you have any special caveats when transplanting with patients with lupus nephritis, like your protocol?
Uh, Not really. I mean, like, the previous speaker just elucidated very properly that serology doesn't really correlate with the recurrence. And what is a good time to transplant, even though it is kind of a
So, please go ahead.
yeah. So I suppose if there are no clinical extrarenal flares, we should go ahead and transplant the patient. Obviously, the more important thing is to be sure about the infection status and the tuberculosis status in our patients,
Hmm.
because that those are far more important when it comes to transplanting patients with lupus nephritis. They should not be having an active infection, particularly tuberculosis, which must be ruled out. Otherwise, we'll have a more difficult time managing them post.
Hmm. So, do you suggest, like, let's say, one flare in the past 6 months or one flare in the past 2 years, like that to be a good criteria to proceed with transplantation?
See, the further they are from their flares, the less chance that they will have a difficulty post transplant.
Right.
That is very well accepted.
Yeah.
Uh, each case has to be treated in an individual fashion based
Hmm.
on the merits of the particular case, and also depending on how they are doing on the treatments that they are on.
Hmm.
Like
Hmm.
somebody is not doing well on dialysis, then you
Hmm.
might relax the criteria a bit. Whereas
Hmm.
somebody who is doing very well, you might want them to wait for the flare to burn out totally before they are considered for transplant. At least 6 months without any flares should be ideal.
Right. Right. Sir, and one thing I think, can an SLE patient be a kidney allograft donor?
Uh, Ideally, no,
Hmm.
because our basic thing when it comes to kidney donation is do no harm.
Yeah.
So putting a lupus patient, even though suppose the patient has been in remission for say 5 years without any medicines,
Hmm.
still the patient of that particular patient having a lupus flare again in their life is much higher than somebody else who has no lupus at all.
Right. Right.
So ideally, a lupus patient should not be a donor.
Hmm. But then, the reason why I'm asking this question is because I read somewhere that it is a relative contraindication. It's not like you cannot take a, because not
See,
all SLEs will develop lupus
no, so
nephritis.
all over, I mean, we
Yeah.
have started accepting diabetic donors with these caveats, right?
Yes. Yes. Yes.
So, how much we want to really stretch the definition of extended
Yeah.
criteria donors is up to our own practice. So
Right.
sometimes we rationalize that it is for the greater good.
Yeah.
A 70-year-old diabetic mother without any diabetic complications, very well controlled, donating to a 35-year-old son, I find it reasonable.
Hmm.
But
Right.
that is not what is there in the literature, right?
Yes. Yes. Right. So one question is by Dr. Tanmay Wagh. He's saying, is it practically possible to do anti-C1q monitoring for early lupus nephritis and relapses of lupus nephritis? Anybody can take the question, please.
I don't think this is easily done or reproducible as of now.
Yeah.
So, Dr. Tanmay, if you have experience, please share, because theoretically it sounds very good. If it is possible to do on a regular basis and reproducible results. That being said, with our current clinical armamentarium, we are able to manage these patients very well in practice, right? Most cases we really don't get into problems.
Right. So I'd request, thank you, sir. In fact, I wish we had more time because, it is an interesting discussion. But I'd request Girish sir to come in and give his comments.
Thank you so much, Purva. Am I audible?
Yes, you are audible, sir.
So,
The next
the words of wisdom by Rishi sir is that the lupus nephritis is a disease in evolution. So that is, I think, is the take home for today. We need to keep discussing about this particular topic. And as the series of webinar has begun with nephropathology, I think we should all thank Dr. Pooja for an excellent insights in the histopathology, and that will help us. All these days we are all focusing on the cellular components of lupus, but I think as the discussion is going on, we need to find some more biomarkers which will guide us and for the better management of this patient. But I think the take home is it's a disease in evolution, and we'll keep on discussing these things more often. So very, very thank you, Rishi sir and Santosh sir. Good to see you after a long time. Thank you so much. Thank you, everyone. And I think Purva should continue discussing lupus for a few more webinars.
Sure, sir, sure. So with that, we come to an end. Wish you all a Shubh Navratri and have a great.
Thank you, Purva.
Thank
Thank you,
you.
Girish,
Thank
for
you,
the
sir. Thank you so much.
invitation.
Thank you,
Bye-bye.
sir.
Thank you, sir.
Thank you, everyone. Thank you so much. Girish sir,